ก็สวัสดีครับผมพันโทชมานินุ้งพลายนะครับก็จบจากวิทยาลัยแพทยศาสตร์พระมงกุฎเกล้ารุ่นที่23นะครับก็สำหรับผมได้รับมอบหมายจากทางกองออร์โทปิดิกให้มาสอนนะครับในหัวข้อเรื่อง common foot and ankle injury นะครับให้กับน้องนักเรียนแพทย์ชั้นปีที่5โดยผมได้เลือกนะครับมาทั้งหมด3เรื่องที่เราพบว่าเป็นเรื่องที่เจอได้บ่อยๆนะครับในชีวิตความเป็นแพทย์เราหนีไม่พ้นภาวะการบาดเจ็บทั้ง3อย่างนะครับที่ผมจะนำมาสอนน้องๆในวันนี้หัวข้อที่1ก็คือหัวข้อเรื่องของ lateral ligament sprain นะครับหัวข้อที่2คือหัวข้อเรื่องของ Achilles tendon rupture หรือเอ็นรัดไหล่ขาดและหัวข้อที่3คือหัวข้อเรื่องของ ankle fracture นะครับหรือกระดูกข้อเท้าหักผมได้รับมอบหมายนะครับให้สอนน้องๆนะครับในหัวข้อต่างๆโดยการใช้ภาษาอังกฤษซึ่งก็เป็นนโยบายจากทางพกสนะครับแล้วก็มอบหมายไว้ยังภาควิชาให้สอนน้องๆในการโดยการใช้ภาษาอังกฤษนะครับนั้นก็อาจจะมีปัญหาอยู่บ้างในคนที่ใช้ภาษาอังกฤษไม่ค่อยได้ดีนะครับแต่ว่าผมคิดว่าภาษาอังกฤษเป็นสิ่งจำเป็นซึ่งน้องๆจำเป็นที่จะต้องใช้นะครับให้คล่องแคล่วเพื่อจะเป็นประโยชน์แก่น้องๆเองในอนาคตนะครับโอเคนะครับผมก็จะขออนุญาตเข้าสู่นะครับหัวข้อเหล่านี้เพื่อที่จะน้องๆจะได้นำประโยชน์ที่ได้เรียนในวันนี้ไปใช้นะครับโดยเฉพาะใครที่จะอยู่เวรห้องฉุกเฉินวันนี้นะครับหรือว่าเมื่อไหร่กลับมาทำงานแล้วจะได้มาอยู่เวรห้องฉุกเฉินก็อาจจะได้เจอคนไข้ที่มีปัญหาดังที่ผมจะได้นำเสนอดังต่อไปนี้นะครับ so I'm gonna switch the mode to the English versions. So the first topic we're gonna talk about lateral ankle sprain. So I'm gonna start with Wayne Rooney twisted his right ankle during the soccer game, and another video show American football player twisted his left ankle during the game, and another basketball player twisted his left ankle during shooting the ball, and the last one is a gymnastic player. She also twisted her left ankle during landing on the ground, as you can see here. So the aim of topic today, I'm gonna focusing on introduction, history and physical examination, investigation, treatment, and the guideline for management of the people who have injury from the lateral ankle incidents. So lateral ankle sprain is one of the most common ligament injury in human body, and it is the most common musculoskeletal injury in ER room. In Thailand, they have no real incident of the ankle sprain. Based on a literature review, we found one study from England. The report 3 to 5% of the patients who came to the ER with lateral ankle sprain, and approximately 5,600 patients per day, and almost 300,000 patients per year. Age group, it usually occur between 15 to 35 years old, but actually it can occur in all age groups. When we compare the location of the ankle sprain between the medial side and the lateral side, we found they by far commonly occur in the lateral ankle sprain. You can see 0.9 per 1,000 athletes, compared to the lateral side that we can see 0.06 per 1,000 athletes for medial side ankle sprain. Another important thing that we need to understand is anatomy of the lateral ankle ligament. So this ligament consists of 3 groups. The first group we call anterior talofibular ligament or ATFL. So this ligament located in the front of the ankle, that's why we call anterior, and it attached from the talus to the fibula. That's why we call talofibular ligament. Another ligament is located in the middle way. It's not in the front, as it's not in the back. That's why they didn't put the name anterior posterior in this ligament. But this ligament attached from the calcaneus to the fibula. That's why we call calcaneofibular ligament. And the last one, this ligament located in the back of the ankle. That's why we call posterior, and attached from the talus to the fibula. That's why we call posterior talofibular ligament. So when we talk about the stability and strength of the ligament, so we found the anterior talofibular ligament is the most weakening or weakest ligament in human body, and most of the time, I would say 95% of the time, this ligament also rupture. And the next ligament that's stronger than the ATFL is the CFL. It usually rupture after the ATFL completely torn. And the posterior talofibular ligament is unlikely to be torn because most of the position of the ankle it usually stay on slightly plantar flexion, which is leading to flexibility or on the relaxation mode on this ligament. So when you have ankle sprain, it's unlikely this ligament to be torn. However, they have two special situation that this ligament can be torn. It can be torn in a totally ankle dislocation, or some patients have direct injury by sharp objects, directly injury to this ligament. So both of these situations can cause PTFL injury. The history of the ankle sprain, patients usually present with pain, and pain usually occur on the outside part of the ankle. If the pain occurs in the inner part, that would be medial side ankle sprain. Another important question is mechanism of injury. We need to ask the patient what kind of accident that happened. So the twisting ankle during standing, walking, running, or jumping. And we also ask the position of the foot at the time of injury. Are there inversion injury? So the ankle will roll inside as shown on the left-hand side picture. And inversion injury usually affects on the lateral ankle ligament. So another question we should ask the patient, can they walk or not? If they be able to put weight on their feet and they can walk more than 4 steps, this can help us. The injury may be minor, but it's not 100%, but it's likely to be minor. So the last important question, oftentimes patients usually present with us and they complain that they heard the popping or snapping sound during the injury, and they're usually confident that their tendon is 100% ruptured. So they have one interesting study focusing on the popping and snapping sound, and they found only % of the patient have true rupture. So this doesn't mean 100% tendon or ligament rupture if you hear the sound. So when we know the history that we should ask, and the next step is a physical examinations that we need to understand. So patient with ankle sprain, they usually present with swelling. Swelling that we should be focusing, it means appropriate swelling. It means they will see the swelling within 1 or 2 hours after injury. If you have injury last night and when you wake up in the morning, you just see swelling, so this may not be serious. But if you have injury an hours ago and you look at your foot and it's like big swelling at the right bottom picture, so this is means serious injury. And some may be present with the ecchymosis or bleeding underneath of the skin. So this is likely to be 70 to 80% that will be serious injury and commonly be fracture, ligament or tendon torn. And also the point of maximum tenderness that will help we differentiate other pathologies. The first picture, if the pain is around the bed of the fifth metatarsal, it can be fifth metatarsal fracture. If the pain at the lateral side around the tip of the fibula, it can be lateral ligament injury. If the pain was slightly above the ankle and the lateral side, so this can be a syndesmotic injury. And as I mentioned earlier, if the patient unable to bear weight more than 4 steps, it's usually likely to be injury. And also neurovascular status is something that we need to be focused and cannot ignore, because when ankle sprain, we usually see a neurological injury. In the ankle sprain grade 2, we can see approximately 17%, but for the sprain grade 3, we see 86%. You see that is a high number of the patient who have nerve. So the next step is a special test. Okay, the first one we call anterior drawer test. So we use one hand and grab on the distal parts of the tibia, and another hand was grab on the bottom of the heel and try to move the heel forward. If you can move the foot forward more than the other side, 3 millimeter is indicated positive anterior drawer test. It represents the ATFL is torn. Okay, so the left hand side is normal. Right hand side, you can see there, you see the sucking sign or skin dimping. So this represents the positive anterior drawer test. So here's another video that you can see. This is the ATFL ligament. And when you perform a drawer test, you will see they have a tension on the ATFL, and you can see they have a gap. See that gap widening, okay, on the front of the ankle. So it means they have ATFL injury. So another test is we call the lateral test. This is the test for the CFL. You can perform by just one hand grab on the distal tibia, and another hand grab on the calcaneus and try to do the valgus stress test. So if you can opening up on the lateral side more than the other side, 10 degrees, this test is positive. So you can see the video on the left hand side, you can see that they open up more than the left hand side. So we'll go the same. Okay, one more time. You will see the difference, okay, between the left and the right. So this is on the lateral side, so you can see this normal side, and you see the abnormal side that we can go more. Okay. And this is the test for the lateral, and you can see this is the real patient. You can see they have a lot open up underneath of the fibula. It represents the calcaneofibular ligament rupture. So I think another thing that's important for our medical student and also general physician is Ottawa ankle rules. So this rule will help or guide us to send the investigation appropriately. When we see the ankle sprain, it doesn't need that we send all of them to do x-ray. So we will send if they have positive Ottawa ankle rules. So the positive is mean. So number one, we should send in the patient age greater than 55 years old, because they usually have osteopenia or osteoporosis, so they can have fracture easily. And number two, they are unable to bear weight more than 4 steps. If they can walk only 1 or 2, 3 steps, it means they might have something serious. Or when you perform a physical examination, if they have pain from the tip of the fibula to 6 centimeter, and on the fifth metatarsal base, they need x-ray. And on the medial side, if they have pain from the tip of the medial malleolus to 6 millimeter approximately, and also pain on the navicular, we need to send the x-ray to rule out the fracture. When we send an x-ray, what we look for, second time we're going to look into the avulsion injury on the tip of the fibula. And sometimes twisting ankle can cause this fibular fracture as well. So we need to look into the fracture line. So MRI of the ankle is another good thing that can provide us more information but we not routinely use an MRI in acute setting because the price is quite high. In government hospital, the cost is 8,000 Thai baht. In private hospital, the price can go up high to between 16 to 24,000 Thai baht. So when should we send the patient to do MRI? We usually send approximately 4 to 6 weeks if they have persistent pain and swelling on the ankle. When we look into MRI, we usually look into the axial view. So here was the TELUS. Okay, this represent Thailand map. This is the mainland. And the small here we call Phuket Island. So the ATFL, it represents the bridge we call Sarasin Bridge. So the good bridge need to be attached from land to land. Okay, this is the ligament here. So if the ligament doesn't attach from land to land, or the bridge has broken on the mid substance, or even the bridge is gone, so we can tell this patient have ligament injury. So I'll look into an example. So this case, okay, I will draw the picture here. This is the mainland. This is the Phuket Island. So the good ligament, as I mentioned earlier, it should be attached from land to land. But you can see here, they attach at Phuket, but they go into the sky. So they're supposed to be attached to mainland, but they wasn't, okay? They're supposed to be go like yellow line. But this patient, they go on the red line, which is not attached to the mainland. So this have the ligament. So another example. So you can see here, this is the mainland, okay? And this is the Phuket Island. And then you can see the ligament, it attached from mainland, but it's just go away, disappear. And then you see the fibula there, and no ligament at all. It means completely torn of the ATF. So this is another example. You can see here, this normal ligament, okay? And they have some gap here. And also the ligament is completely torn and not attached to the mainland. So for the grading system, we have 3 grades of ankle sprain, depend on the severity of the injury. So normal one, you can see here, okay, the ligament is short, okay, and thick, okay. And for the grade 1, it's stretched out. You can see it's thinner than before, okay. And they have a torn, but you cannot see by eye. You should use a microscope to see. And grade 2 is partially torn. It can be 10%, 20%, 30%, 40%, or 50%. And finally, for the grade 3, it's been completely torn. You can see that there are separation of the ligament from each other. So another thing that you need to be focusing is associated injury. Normally ankle sprain usually better in 6 weeks if the patient have persistent pain and swelling more than 6 weeks. So we can see a syndesmotic injury. So as shown on the left picture, you can see they have a whitening streak between the bone. Okay, normally in the T2, water is going to be white color and bone will be black color. This area is supposed to be full area and shouldn't have water inside. But when the ligament is torn, then the water can go and sneak in between the bone. And we can see this is positive for the syndesmotic injury. So after that can cause associated injury on the ankle. It can be a cartilage damage. It can be a bone injury or occult fracture. So you should look for if the patient have persistent pain, MRI is indicated. Okay, this is important. You need to understand this. For treatment, usually we have 2 concepts of the treatment. The first one is conservative management, and the second one is open surgery. So for the long immobilization is all treatment. Usually we put cast on the patient between 3 to 6 weeks. But nowadays we no longer use these techniques because it can cause ankle stiffness, scar formation, muscle atrophy, loss of proprioception, different thrombosis, and also poor functional score and slower recovery time. And what should we do now? So when we see the patient with ankle sprain, we usually immobilization them in a short period. It means less than 2 to 3 weeks. And then following in by functional rehabilitation, or we can do the rehabilitation as soon as possible. So this was proved by research that show us they have faster recovery time and higher functional score. So why we saying that if you do an early range of motion as shown here by move the ankle up and down and in and out, so this can stimulate and make the ligament, the new ligament, stronger than before. It's better than you put them on a cast for 4 to 6 weeks. And after you perform a range of motion exercise in the first 2 weeks, after that, you need to encourage the patient to do the strengthening exercise. So once they gain strength, so they'll be able to return to their activity. Conservative management that we usually advise for the patient. We use RICE protocol, including rest, immobilization. I prefer to use splint more than cast because cast can cause compartment syndrome. I think if you graduate from PMK hospital, you're supposed to put a splint for the patients. And also icing, we can use icing. I usually put ice for 15 minutes and then relax for 15 minutes and put the ice back for another 15 minutes. And you can do every 2 hours. And I usually perform maybe a couple days after injury. And elevations, so you should elevate the legs above your heart, approximately 10 centimeters. You doesn't need to go that high. Okay, if you have coronary heart disease in old people, your heart gonna be worked a lot, and then you can produce MI in this patient. So here's the picture to show how should you elevate your leg during sitting down in the chair. And when we talk about conservative management, I suppose to mention the ankle support. So the best ankle support need to be a stirrup between the side. Or usually use a rest up. It means you have similar to the rope that you can tie and make stability for the ankle. So this is supposed to be wearing in the first 2 weeks. But after 2 weeks, you can wearing the soft one we call wrap around ankle support. And the most commonly used in Thailand is a full wrap around. The price approximately 250 Thai baht. For the taping, so I'm not suggest use the tape in acute ankle sprain, but you can use the tape in some patients to have chronic lateral ankle instability, or in some sport player that they have injury during the match. You can give them stability and they'll be able to return to play. And another thing that you need to teach your patient is proprioception. It's not just range of motion of the ankle. Proprioception also important. Once again, improvement in proprioception that will help them return to sport as quick as possible. So when the conservative management fails, so the surgery is indicated, you can repair the ligament. Here, this is an example of your brother. He's, I think, external 4 years ago. I did surgery for him because he had sprained his ankle during basketball game. Which we put to anchor. This is bioabsorbable suture with non-absorbable fiber wire, and then you can use to repair the ligament and create a stability. And here's another example of the picture that how we repair ligament. So this can perform in techniques, or you can perform in the percutaneous, which is minimally invasive, or you can perform in arthroscopy. For take-home message, so students need to be understand on anatomy of the ligament. So which ligament is the most weakest one and likely to be injured. And as I mentioned earlier, ATFL is one of the most common ligament injury in lateral ankle sprain. And when you see the patient with ankle sprain,
and if they have persistent problem more than 4 to 6 weeks, so you should look into the associated injury. And one of the most important investigation is the MRI. It's one thing that can provide us the information. Okay, this thing that you need to review and understand for the lateral ankle ligament injury. And if anyone have a question, you feel free to send me or ask me anytime you want. So I can give you my line ID at the end of my presentation.